Welcome to this lecture on breast cancer imaging using F18 fluoroestradiol. These are the objectives for this presentation. Breast cancer is the second most common cancer in the U.S. In fact, 1 in 8 women will be diagnosed with breast cancer. Death rates for women are higher than other cancers besides lung cancer. And the death rate is dropping in recent years due to early detection and improvements in treatment. Imaging for breast cancer includes mammography, ultrasound, computed tomography, MRI, nuclear medicine bone scans, and FDG PET CT scans. Common biomarkers for breast cancer include estrogen receptors, which are steroid receptors for estrogen, human epidermal growth factor, receptor 2, this would be the HER2 or the ERBB2 growth, these are growth factor receptors. The Ki67, which is a marker of cell proliferation, and then progesterone receptors, which are steroid receptors for progesterone. Breast cancer stages range from 0, which is pre-invasive, to 4, which is the most metastatic. Stage is often a prognostic factor. Early stages have a better long-term outcome than advanced cancer stages such as 3 and 4. And the stage is based on the T&M system, which is tumor characteristics and size, and this is graded T0 to 4. Lymph node metastases, which is graded as N to 1, or distant organ metastases, which is graded as 0 to 1. Understanding the stage does help clinicians to determine the right treatment, and it is a very huge prognostic factor to figure out the stage at the time of diagnosis and to restage as the cancer progresses. So ER is a predictive factor, the estrogen receptors. These patients will respond to endocrine therapy, and about 50 to 70% are ER positive, which is a better prognosis. So to expand a little bit on the subtypes, the two most common types of breast cancer are ductal, which is about 80% of those who are diagnosed, and lobular, which is about 10 to 15%. So the 4 molecular subtypes are based on the estrogen receptors and progesterone receptors, HR2 status, and then the Ki67 and hormone receptors. Like I said, the ER is the estrogen receptors and PR is progesterone. These will respond to hormone therapy such as tamoxifen. That's probably the one that's most commonly heard of. And the HR2 positive status, this is the human epidural growth factor receptors, and the HR2 causes cell proliferation. This is treated with HR2 targeted therapies, which blocks the cancer cell growth. And the Ki67 is a proliferation marker, like I said on the previous slide, but it determines if cells are quickly dividing or proliferating. So this is kind of a marker of how fast the tumor is growing. Less than 10% is low, 10 to 20% is borderline, and then greater than 20% is high. So you look at the last slide here, the last column there, the treatment implications for which ones respond to chemo, which ones respond to hormone therapy, and so forth. So this slide shows us the screening, diagnosis, and staging, how breast cancer is managed It is imperative to get the subtype at the type of diagnosis, and this is done via biopsy. Receptor status is determined by a combination of biopsy and immunohistochemistry or IHC testing. So looking for ER and HER2 positive receptors because those are associated with a better outcome, better prognosis for the patient. And physicians will look at the overall percentage of cells that have receptors present. So early screening and detection is done by self-exam, clinical exams, and screening mammograms. But once a patient is diagnosed, that imaging and especially the biopsy are very important to find that whether or not they have the hormone receptors present. So imaging would include a diagnostic mammogram, MRI, and ultrasound. Once it's confirmed or highly suspicious of cancer, that's where the biopsy comes into play. And doctors will look at, or clinicians will look at the pathological diagnosis, the presence of hormone receptors and HER2 receptors, and then the genome profiling. Even though biopsy is the gold standard, I do want to point out that there are some limitations for that. First of all, there's a couple different types of biopsy. The fine needle aspiration is where a small needle is used to get a sample of fluid or tissue. The core biopsy uses a large needle, and there's also open surgical biopsy where an incision is made during the surgery. All of these biopsy types are invasive and very painful. The amount of tissue that's obtained may not be sufficient. So multiple sampling is often needed. And especially if we're looking at intratumor heterogeneity, it's very important to get multiple biopsies and multiple samples. So the tumor itself may not be homogeneous. In the case of metastatic breast cancer, it's very limited in the number of samples you can obtain, but your ability to effectively assess the tumor heterogeneity is limited by the number of biopsies that you can take. So it is recommended to repeat biopsy at any recurrence of breast cancer and to reassess the extent of heterogeneity within the tumor. Now, once the person is diagnosed with cancer and they go through evaluation for staging, restaging, recurrence, that's where imaging comes into play as far as nuclear medicine imaging. So chest x-ray, CT, MRI, and ultrasound are useful. Bone scans, traditional nuclear medicine bone scans with HDP or MDP or even sodium fluoride are helpful for looking at bone metastases. But PET scans and FDG have been traditionally used, and this is also where the F18 FES studies come into play. So there are three main types of tumor heterogeneity. Heterogeneity is very important to understand and assess because it will contribute to low treatment response rates. And heterogeneity exists in about 30% of metastases. This does have implications for treatment and what will effectively work for the patient. For example, some lesions could be ER negative while others are ER positive. Treatment decisions from a single biopsy could be ineffective if the patient has heterogeneity, and an FES scan can assist in characterizing the lesions in the whole body to determine, the extent of heterogeneity, which ones are ER positive and which ones no longer are. So if a single biopsy is made at a single site at a single point in time, the treatment could be based on that, but that information is incomplete and imperfect. So the patient could be placed on an incorrect or inadequate treatment plan. So the three types of heterogeneity are intratumor heterogeneity, intertumor, and temporal. Intratumor is within the single lesion. So you have ER positive and ER negative tumor cells within the same lesion. Intratumor is within a single patient. You may have some lesions that are ER positive and some that are ER negative. Temporal heterogeneity is that the status will change over time, meaning these tumors used to be ER positive, but they no longer are. That is a very important thing to consider as the tumor progresses, because tumors will have some heterogeneity, but will become more so as the tumor progresses, and they can also change type. So the temporal heterogeneity comes into play here. Patients that were previously treated with hormone therapy who were ER positive, their cells may lose some of those ER receptors over time as they become more malignant and they modify to become more treatment resistant. There are studies that have shown that temporal heterogeneity, where tumors that were previously hormone recepting positive now become triple negative, and that loss of hormone receptor status is significantly associated to risk of death because it becomes more treatment resistant and it has less less response to treatment. So discordance of the hormone receptors and HR2 expression become primary in metastatic cancer, cannot be neglected. The HR loss is associated with higher death rates, worse survival, worse prognosis, and more resistant to treatment. So sampling those sites and figuring out the subtype and the level of heterogeneity is extremely important for managing the patient's care. I would also like to point out that two sites that are most common for having heterogeneity are the lymph nodes and the bone, bone being the most common, followed by lymph, but it can happen anywhere, and biopsy of bone can be very difficult. So that's where the FES imaging is very helpful. Now, again, the best survival is if you are hormone receptor positive and stay hormone receptor positive, followed by if you're ER negative and become positive, or the other way around. However, there is a clear separation between if you start negative and stay negative, and versus if you start positive and become negative. Once a patient relapse, if they are ER negative, overall survival at that point is the same as somebody who's been negative all along. So very important to understand when ER positive patient becomes negative so the proper therapeutic choice can be made. So this is one of the key areas where the F18 FES study, especially in conjunction with an FDG study, are extremely important to the patient. So that brings us to the rationale for F18 FES imaging. This is estradiol, which is a form of estrogen produced within the body for tissues of the reproductive organs. And estrogen receptors are overexpressed in patients with ER positive breast cancer. So imaging the estrogen receptors allows for visualization of all ER positive lesions. PET-CT imaging offers a highly sensitive quantitative measure of ER positive receptors expressed in ER positive breast cancer. The detection of estrogen receptor lesions is an adjunct to biopsy in patients with recurrent or metastatic breast cancer. This does not replace other imaging or a biopsy. Limitations of use: tissue biopsy should be used to confirm the recurrence of breast cancer and to verify ER status by pathology. Cerianna is the trade name for F18 FES, and Cerianna is not useful for imaging other receptors such as the HER2 or the progesterone receptors. The radiopharmaceutical is F18 fluoroestradiol, also referred to as FES or trade name Cerianna. So the F18 portion is cyclotron produced radionuclide, Energy is 511 keV, but it decays by positron to stable oxygen 18. So we'll refer to it from here on out as FES. And estradiol functions in the human body to mature and then maintain the reproductive system. The estrogen receptors found on tumor cells use estradiol to replicate, and hormone therapy removes estrogen from the body in a way, kind of starving those tumor cells. So, estradiol is the compound or the molecule that F18 is tagged to. So this is going to go to functional estrogen receptors and allows for whole body visualization of any cells in the body that have estrogen receptors. There are a few contraindications or more or less considerations for an FES study. It is not useful for imaging other receptors such as HER2 and the progesterone receptors. Pregnancy is a relative contraindication, not an absolute one. It is important to assess the health risks for the baby and the mom when determining whether or not the test is really needed, and that is should adhere to institution protocol for that. Recent nuclear medicine studies are not an absolute contradiction either. This is dependent on the radiopharmaceutical and the half-life, how much activity may be left in the patient, and whether or not it was a PET study. And breastfeeding, also relative contraindication. It is recommended that the patient should waste the breast milk for 12 hours after injection. Systemic endocrine therapy use may reduce FES uptake. The estrogen receptor modulators and down regulators will block the estrogen receptors. So long-acting ones like fulvestrant should be removed or withheld for 28 weeks. I know it sounds like a really long time. Short-acting ones like tamoxifen should be withheld for 8 weeks. It is recommended, because that is a really long time to withhold those, that the FES imaging be performed before starting the ER blocking endocrine therapies. Less than 1% of patients who received FES imaging had adverse reactions. Less than 1% reported injection site pain or dysphagia, which means loss of taste. That's also transient, not permanent. So it is recommended not to delay therapy for an FES scan if the patient needs systemic endocrine therapies, but the FES should be done prior to starting those therapies. And then, like I said, if the patient is lactating, that needs to be wasted. Other than withholding the hormonal therapy, patient prep is fairly easy for an FES study. Patients do not have to be MPO. They don't have to reduce exercise. You don't need to take their blood sugar before starting. They don't have to follow a special diet. None of those things that need to be done for FDG imaging. It is encouraged that patients should increase their hydration before and after injection, and they should be encouraged to void frequently. We don't want a lot of activity or urine in the bladder when we image them. And then instruct the patient on imaging. So the total test time will take about 2 to 3 hours. Physical requirements include having the patient lay supine with their arms above their head. Any potential side effects, recall that loss of taste that's temporary is probably one of the most common, and that occurs in less than 1% of patients. And then stress to the patient the importance of hydration and voiding frequently. When starting a patient for FES study, it is important to include a very detailed patient medical history. This should include assessment of pregnancy and breastfeeding status, recent diagnosis test and results, including results of all lab values and diagnostic imaging studies, lab include biopsies. So the result of biopsies and the heterogeneity or anything like that that may have showed up in a biopsy. The results of FDG PET, bone scan, CT, MRI, mammo, and then current medication list, including therapies such as the estrogen receptor modulators or down regulators. As far as the acquisition goes, the patient will be injected with 6 millicuries. Now, this is a range of 3 to 6, but 6 is the most common. And it is important to note that this injection should occur over 1 to 2 minutes. Don't administer it as a bolus. This should be administered slowly to the patient. It is recommended to start the imaging time at 80 minutes, although the range could be 20 minutes to 80 minutes after the drug administration, and that's dependent on the workflow of the department. But 80 minutes, 60 to 80 minutes or 80 minutes is recommended. And then the patient will be positioned supine with their arms above their head. Before putting the patient on the table, though, recall that we wanted them to be well hydrated and void often. So you will want to have the patient go to the restroom before starting their scan. And then once they've done that, you can position them supine with their arms above their head. This is the overall protocol for it. The dose will be provided in less than 10 milliliters volume, and traditionally it's about 6 millicuries given IV slowly over 1 to 2 minutes. That should be followed with a flush of at least 10 milliliters of volume, just to make sure that it all goes through the tubing. You don't want any activity to be stuck in the tubing. You want it all to go into the patient. So you will want to flush that well after injection. And then the uptake, like I said, 80 minutes is most common. You want probably at least 60 to 80 minutes, but you can go as soon as 20 minutes if needed for the workflow of your department. Patients should hydrate and void frequently, though, and they should void before being placed on the table. Place them supine with their arms extended over their head. The energy window is 30% centered on 511 keV. If you're using a GE Discovery ST, you will scan them in 2D mode with unless it has a dimension upgrade. You'll scan the patient vertex to mid-thigh. You can do whole body if they have mets on the lower legs. That was seen on any other imaging, but typically you'll just go vertex to mid-thighs. And the CT parameters are used for localization and attenuation correction. The KVP setting will be 130 and the MAS will be 90. The acquisition is about 3 minutes per bed position if you're using a GE Discovery. Now for Siemens, you'll scan them in 3D mode and or United Healthcare Imaging. That will be recommended for 3D mode also. And then bed position and scan parameters are the same. If you're doing CT for attenuation correction on the Siemens camera, the Siemens care dose may be utilized. And then Siemens, it's about 2 minutes per bed position, unless the system has a variable time option. United Healthcare Imaging may be the same. You will want to reach out to your provider and make sure you're following their recommended guidelines for imaging. So for the image processing, if you're using a Siemens Horizon, the matrix is 180. You'll do 4 iterations of iterative reconstruction with 10 subsets. Use a Gaussian filter, full half max of 5, and a zoom of 1. If you're using a GE Discovery 180 matrix, 4 iterations, 10 subsets, this is an OSEM. The post filter is 86, loop filter is 4.69, Z-axis filter is yes, diameter 70, center the left is 0, in the center the P is 0, and the attenuation type is measured. So these are the recommendations that come from Cerianna directly when the drug was released. So you may want to work with your manufacturer if you have a different camera or you're unsure of how to set that up and you're starting FES imaging for the first time. I do not have the parameters for any other scanners, so at that point you would also want to contact the camera manufacturer to get assistance in setting up that protocol. With image interpretation and display, you'll scale and display the reconstructed views, anterior and posterior torso, and the maximum intensity projections, display transaxial, coronal, and sagittal planes, and then rotating MIP, and then surface rendering 3D displays can be used to facilitate lesion evaluation. This is the normal biodistribution. The liver will have the highest radiation dose. It is the critical organ. It is common to see intestines and intrahepatic circulation. It has renal clearance, so you will see kidneys, ureters, and bladder. There should be low-level uptake and low ER expressing tissues, such as the lung and the white adipose tissue. FES uptake correlates directly to the level of estrogen receptors in breast cancer, other tumors, and non-cancerous pathologic conditions. Comparison should be made to the blood pool as a reference, and comparison should be made outside of organs of high physiologic uptake like the liver or urinary excretion. Uptake greater than the liver is due to estrogen receptor overexpression. So there's a couple things to keep in mind with interpretation. The uptake will depend on the density of estrogen receptors, and you may see uptake in physiologic tissues like the ovary or the uterus, and that could lead a false positive study if it's not considered. And interpretation is qualitative. So that is where that comparison of uptake to tissue background is going to be really important. Make sure that you're not comparing it to the liver, the hepatobiliary system, or urinary where it's excreted. And the detection of the ER positive tumors really has to be based on that background. SUV values can be used to help validate the qualitative information, especially if you are qualitatively just visually comparing it. It will help doctors to use SUV values to help validate that. The SUV max threshold is 1.5, but interpretation should not solely be based on the SUV values. Background SUVs will vary for different tissues. Recent ER antagonists will make the SUVs unreliable, and the partial volume effect may interfere with the accurate calculation. So that's why it is recommended to stick to qualitative assessment and just use SUV as a helpful value in especially complicated cases. So low or absent FES uptake correlates with a lack of ER expression, and so FES PET can help identify patients with endocrine-resistant disease. This is a patient who received FES imaging. On the FES images are on the top, the CT is in the bottom. This is the same patient in transaxial, sagittal, and coronal views. You'll see in T11 there is a nodule that was hot on FDG but cold on Cerianna. And any nodule in osseous or body that is cold is a spot that is missing estrogen receptors. You'll see it down here in T11. So you can see my arrow pointing, my mouse pointing to it right there. It's appearing cold on the FES images. So this is showing you normal physiologic distribution for FDG and FES because most technologists who have been working with oncologic PET imaging are very familiar with the uptake of FDG. You'll notice that FES is different. First of all, the brain activity that's seen in FDG is not present in FES. So if you're looking for metastases to the brain, you cannot evaluate that with FDG, but with FES you can because you don't typically see brain activity there. And so FES is the only one that allows for visualization of the ER positive lesions in the brain. Next, look at the liver activity. The liver activity is not hot on the FDG study, but it is on FES. And this is a limitation of the fluoroestradiol studies. The liver disease cannot be identified with FES, or at least not easily, because you see so much activity already taken up by there. If you think about physiologically, normally the liver is the organ in our bodies that processes hormones and clears them out of the bloodstream. So it would make sense that the liver is hot on FES studies. And so you can also see that there's prominent bowel activity. So that is a limitation of FES imaging that makes FDG imaging valuable. You do see some faint bone marrow uptake with FDG that is not seen on FES. Both of them will have bladder uptake, and so both of them, it's important to have the patient void right before putting them on the camera. If that is suspected and it's an issue, the patient imaging can start at mid thighs and go up to the vertex, similarly to how prostate cancer patients are scanned. And then you will also see, or may also see, uterine uptake on FES studies, and you will not see that on FDG. Finally, there is going to be venous activity uptaking at the site of injection. This is one of the reasons that it is important to use a slow injection, followed by flushing of at least 10 milliliters of saline. It is better to do a little bit more so you can help clear some of that residual venous uptake. So remember, these drugs are very different. They have very different roles in imaging breast cancer patients. With FDG, you're looking at the glucose metabolism to find where the disease is and if it's metabolically active. But the lesions may not show up if they are hormone recepting lesions. So with FES, you're looking at the estrogen receptor status and seeing if they are estrogen receptor positive lesions. ER positive disease is seen on both FES and FDG. If it is indolent disease, it may not be seen on FDG, and the ER negative disease is seen on FDG but not FES, and that's the one that has the worst prognosis. So it may also be helpful to do both scans to identify the heterogeneity. You may have some areas that are positive on FDG and some that are only positive on FES studies. In this image here, you do see where the patient has some, in the first ER positive disease, you see that the lesions are positive in both images, but in the ER negative disease, you see that the FES study is negative, but the FDG is positive. These are two patients. The scans were done prior to therapy. With patient A, there is mediastinal lesions that are appreciated by both FES and FDG. Core biopsy of the metastatic axillary lesion showed ER positive breast cancer. That's this one. And then patient B also had mediastinal disease. You see it down here. And that's clearly seen on the FDG, but not visible on the FES study. and the needle biopsy showed that the patient did have ER-negative breast cancer. This study specifically looked at heterogeneity in bone metastases, trying to see if there was a prognostic role for inter or intra heterogeneity of disease. Patients had both FDG and FES scans to identify heterogeneity. FDG scans show all metabolically active lesions, and the FES only shows the ER positive lesions. The assumption is that lesions seen on FDG and not FES are estrogen receptor negative. So this would represent some heterogeneity. And this example really also highlights the prognosis for patients who are ER negative versus those who are ER positive. The patient on the left was a 53-year-old woman. FDG detected a lot more of the metastases than the FES study did. And so this patient had ER negative metastases, but you do see that there is some heterogeneity because there are some lesions that are showing up on the ER positive study. There's just a lot more ER negative lesions within this patient. This patient suffered from disease progression and subsequently died 20 months later. The patient on the right, however, had much fewer bone metastases, and the the FES study has a lot more noticeable lesions on it. This patient had predominantly ER positive metastases and did not suffer from disease progression over time. So this patient actually survived the breast cancer. So very interesting cases there to show how both FES and FDG can be used together to help determine the patient's prognosis and treatment plan. This is a case of invasive lobular carcinoma, which demonstrates lower conspicuousy for FDG PET than the common invasive ductal carcinoma. Other molecular imaging methods may be needed to evaluate those particular malignancies, but in this case, the invasive lobular carcinoma is nearly always, really almost 95% of the time, the invasive lobular carcinoma is estrogen receptor ER positive. And so ER targeting PET tracers such as the FES are really valuable in these types of patients. You see that this patient will probably have a better prognosis and will greatly benefit from hormone therapy because almost all of their lesions are estrogen receptor positive and not very much is really seen on the FDG. These are two separate patients. Patient 1 is on the top row and patient 2 is on the bottom row. So top row is the FDG study, the Siriana study in the middle, and then FDG follow-up. This patient was HR positive and responded to treatment. And as you can see in image B shows the baseline of the FES study and the ER expression in the axial skeleton, including the vertebrae, the pelvic bones, even the humerus and the femur, and in the axillary lymph nodes. After 8 weeks, the patient underwent the FDG study showing almost complete metabolic response to the hormone therapy, and that patient was successfully put on treatment for more than 70 weeks and doing well. The prognosis was good for that patient. In row 2, That patient is a non-responder to hormone therapy. The baseline FDG is there in image D. That shows pathologic uptake in multiple skeletal lesions. Image E is the FES study, which only showed very minimally increased ER expression just in the thoracic vertebrae there, as you can see kind of in the chest. And then after 8 weeks of therapy, the FDG was repeated, and you can see that there is absolutely no metabolic response, even some increase in the pathologic uptake in multiple skeletal lesions, which indicate that the patient is getting worse with the hormone therapy. So bottom row again is FDG, Siriana, and FDG in the patient who is HR negative and did not respond to treatment. This is another case of lobular carcinoma. FDG and the FES scan are labeled there. While the disease is present on the FDG scan, the extent of disease is really revealed on the FES study. If only an FDG study were done, you would not see that this patient would benefit from the hormone therapy. You would also not see the full extent of the disease. So FES lesions in greater intensity than the ones that are seen on the FDG. So from all the research that has been done with FES studies, the overall sensitivity and specificity of FES is about 85% for lesions that express estrogen receptors. Specifically in terms of metastatic testing, information about ER expression will have a lower impact on the quality of life because all lesions are seen on one test. A reduction in complications and helps clinicians to make an educated decision on which metastases to sample. Some additional considerations for FES studies. Increased uptake in the draining vein does not mean that it was infiltrated. This is a very important point to make. Sometimes there is activity that is seen in the vein, the draining vein. That does not mean that it is an infiltration. It does not mean that there are consequential health effects for that patient. So it is normal to see some of that activity there, but that is why it is extremely important to inject it slow over 1 to 2 minutes and then flush it really, really well. Hepatic metastases may be masked on FES studies due to the hepatobiliary excretion, and hepatic lesions usually present with decreased uptake regardless of the ER status. And then physiologic uptake may appear in the uterus and the vagina due to the just the increased presence of estrogen receptors in that area, or if a patient has had a hysterectomy in the past, they may show up there as well. Some last additional considerations, there false positives can occur. One of the things that will lead to false positives are radiation pneumonitis, pulmonary fibrosis, other cancers, especially female cancers, ovarian and endometrial sarcoma, and also meningiomas. That's not a female cancer, but that's one that will cause a false positive also. And then some benign breast lesions will actually become false positives, fibroadenomas, fibrocystic changes, and sclerosing adenosis. And then false negatives can actually occur also if there are non-functional estrogen recepting lesions, small lesions that are less than 1 centimeter, lesions near or within areas of normally high physiologic uptake, such as the hepatobiliary tract, the bowel, or even the uterus, and then poor patient prep, not being off the estrogen blocking agents or estrogen receptor blocking agents for the required amount of time could lead to a false negative study. These are the references, and I hope you enjoyed this presentation. Thank you for watching.